Today's lecture will be on regional musculoskeletal pain syndrome. Why it's important to know about this lecture, or why this lecture is important for two main reasons. The first reason is because regional musculoskeletal pain is common. The second, sometimes those patients who have regional pain may present it to you with a medical emergency. So it's important to know about this topic. What should we learn? We need to know about the low back pain, neck pain, shoulder pain, elbow pain, hand and wrist pain, hip pain, knee pain, ankle and foot pain. Why regional musculoskeletal pain is important? As we said, it's a common presenting complaint for the patient. The second, it is age-related degenerative disease of tendon and ligament, like osteoarthritis and trauma. Back pain. How frequent back pain we have seen it in the clinical practice? Back pain can affect up to 80% of people in their lives. Disability from back pain has risen despite stable prevalence. The back pain is considered the top reason for work absence in the Western countries. 7% of the UK adults see their GPs yearly for back pain. Around 9% of those people worldwide suffer from low back pain. How to assess patient with back pain? At first, we need to put in our mind the differential diagnosis of back pain. We need to know the mechanical back pain, the destructive type, inflammatory back pain, and the other causes. The mechanical pain, most commonly, it is of acute onset and self-limiting. The destructive type typically caused by either malignancy or infection, and it's important to assess it accurately. The inflammatory back pain, axial spondyloarthritis, psoriatic spondyloarthritis are important causes. Other causes like disc prolapse, spinal canal stenosis, Paget disease, and fracture. The clinical assessment should include the type of pain, persistent pain, associators, fever, weight loss, inflammatory features, nerve root pain persisting above 4 weeks. This will lead us to further investigation and further recording for image or not. The Codd-Aquinas syndrome necessitates urgent investigation and a neurological opinion. What are the features of mechanical low back pain? The first feature is pain varies with the physical activity and improved with rest. Onset often sudden and precipitated by lifting or bending. Recurrent episodes and pain limited to back or upper leg. And there's no clear cut about nerve root distribution and no systemic features. Those patients who have mechanical back pain, typically the pain is self-limited and recovered at 6 weeks in up to 90% of patients. What are the red flags for possible spinal pathology? In the history, those patients are either less than 20 years of age or above 55 years at presentation. And typically the pain is constant, progressive, and relieved by rest, and dominantly thoracic pain, and the patient has history of carcinoma, tuberculosis, HIV, steroid use, or osteoporosis. And typically, those patients with red flag features of pain associated with constitutional features like sweating, weight loss, fever, and systemic upset. And there's history of major trauma. On examination, There's painful spinal deformity, severe symmetrical spinal deformity, saddle anesthesia, progressive neurological sign or muscle wasting, and multiple levels of root signs. What are the clinical features of radicular pain? Nerve root pain, typically unilateral leg pain, increase more than low back pain, and pain radiates beyond the knee, paresthesia in the same distribution, and there is nerve root irritation signs, reduced stride leg rising that reproduce leg pain, motor, sensory, or reflex signs limited to one or adjacent nerve roots, and often those patients with radicular pain are self-limiting. Up to 50% have recovery at 6 weeks. What about Coda Equina syndrome? Those patients represent emergency, important. There's difficulty with micturition, loss of anal sphincter tone or fecal incontinence, saddle anesthesia, gait disturbance, pain, numbness, or weakness affecting one or both legs. How to investigate patient with back pain? For acute mechanical back pain, there is no need for investigation. For patients with persistent pain above 6 years, MRI is needed, and this is ideal for identifying spinal canal stenosis, cord or nerve root compression, axial SPA, malignancy, and sepsis. For patients with suspected vertebral fracture, we need to do plain X-rays, and it is useful in cases of suspected vertebral compression, fractures, osteoarthritis, and degenerative disc diseases. Those with suspected metastatic disease, we need to do bone scintigraphy or CT, and this is considered when metastatic disease is of concern. What about routine check? We need to do biochemistry and hematology, and this is general health checkup of the patient. For the infection or inflammatory disease, if we're suspected, we need to do ESR, CRP to screen for the infection and inflammatory diseases. Myeloma, we need to do protein and urine electrophoresis. This is specific to myeloma screening. Axial SPA, HLA-B27 is important for the diagnosis. Prostatic carcinoma, we need to do prostatic specific antigen, and this is for a prostate cancer screening. How to treat those patients with pain? First one is education. We need to emphasize the self-limiting nature of the back pain and benefit of exercise. Pain management is important. Regular analgesia and or non-steroidal are important to improve mobility and enable the exercise doing. Lifestyle modification, early return to work and normal activity is important. So we need to avoid bed rest to reduce the risk of chronic disability. Physiotherapy, consider referral to appropriate physiotherapist if normal activities are not resumed in 6 weeks. Medication, we need to give low dose tricyclic antidepressant for pain relief, improvement of the sleep, and to improve the mood. Additional modalities are needed, like epidural and facet joint injection, traction, lumbar support. And these are important, and it's considered as some of limited evidence from the clinical trials, controlled clinical trials. Specific condition, we need to treat the underlying conditions. For issues like malignant disease, osteoporosis, Paget disease, and spondyloarthritis, surgical indication for back pain is required in less than 1% of the cases. Remember, surgery is indicated in less than 1% of patients. For conditions like progressive spinal canal stenosis, for those with severe spinal cord compression or certain severe nerve root compression that is not responding to the conservative therapy, or even can lead to severe functional impairment of the patient. Now we will come to neck pain. What are the causes of neck pain? The common causes are injury, poor posture, stress, and osteoarthritis. Various factors can be a contributable factor to the neck pain. Typically, patients with neck pain resolve this pain. The pain is resolved spontaneously or with simple basic treatment. Most of the cases resolve with simple treatment like non-steroidal anti-inflammatory medications, analgesics, and exercise therapy. Persistent pain management. MRI and potential referral is important for pain following nerve root distribution or with limb neurological signs. MRI and possibly neurosurgical consultations are recommended. Shoulder pain. Common in individuals above 40 years of age. What are the treatment lines? General management, meaning analgesic and non-steroidal, which are considered the first-line treatment of pain management. Sometimes we need local steroid injection to decrease the inflammation and pain. Physiotherapy are important to restore the normal movement and function of the patient. Sometimes we need specific conditions treatment. Rotator cuff lesion, a severe acromioclavicular joint arthritis, surgery sometimes indicated for patients with debilitating symptoms or persistent symptoms. Subacromial impingement, subacromial glucocorticoid injection, and physiotherapy. We need are considered the initial step, especially when no rotator cuff tear is present on MRI. What about calcific supraspinatus tendinitis? It needs barbotage when used when unresponsive to steroid injection. And the complete rotator cuff tear below 40 years, full surgical repair is needed. Effective in younger individuals, less so in the older patients. What are the clinical findings in patients with shoulder pain? For rotator cuff and subacromial lesion, the pain is reproduced by active resistant movement. For the abduction, it indicates supraspinatus injury. External rotation indicate infraspinatus and terespinal muscle involvement or lesion, and the internal rotation for subscapularis. What about acromioclavicular joint? Pain on full abduction and adduction at 90 degrees of forward elevation indicate local acromioclavicular joint pathology. Bicipital long head tendinitis. Typically, there is tenderness over the bicipital groove. Pain reproduced by a resistant active wrist supination or elbow flexion. This figure shows the patterns around the shoulder, patterns of pain. Pain in the shoulder, it can be rotator cuff pathology and glenohumeral arthritis. It can be acromioclavicular joint disease, and it can be bicipital muscle tendinitis. Now we will come to another topic, which is adhesive capsulitis frozen shoulder. Frozen shoulder is a very important, commonly seen in the clinical practice. The pain typically associated with marked restriction of elevation and external rotation of the arm. And the main risk factor for adhesive capsulitis is diabetes mellitus. The second is a trauma and neck or radicular lesion. Remember that early treatment with analgesia and or or local steroid injection and pendular arm exercise are very important, and the recovery can sometimes be late and take up to 2 years to get full recovery. Remember that patient with severe shoulder adhesive capsulitis, frozen shoulder, it necessitates joint distension and manipulation under general anesthesia, or sometimes done under local anesthesia. Elbow pain. What about elbow pain? What are the most common causes of elbow pain? The most common cause is repeated trauma. The lesion for the elbow pain, the site can indicate the local pathology. Lateral epicondylitis cause is typically traumatic tennis elbow or spar-related enthesitis. The lateral epicondylitis, the pain is lateral epicondylar and radiated to the extensor forearm. Tenderness on examination, there is tenderness over the epicondylar. The pain reproduced by resisted active wrist extension, while the medial humeral epicondylitis, which is a traumatic golfer's elbow or a spar-related enthesitis, typically the pain is on the medial epicondylar side and sometimes radiated to the flexor forearm. On examination, there is tenderness over the medial epicondyle and pain reproduced by the resisted active wrist flexion. The third cause of elbow pain is olecranon bursitis, typically caused by gout, rheumatoid arthritis, or infection. The pain typically on the olecranon side and of the elbow, and there is tenderness or there is tender swelling. Best treatment is rest with analgesics and topical or systemic non-steroidal. Sometimes local steroid injection may be given in patients with resistant elbow pain or resistant cases. What about hand and wrist pain? The hand and wrist pain, the pain could be either articular, problem in the joint, periarticular, tendinitis, vascular could be Raynaud phenomena, radicular, C6, C5, C7, and C8 radiculopathy, and could be local nerve injury, carpal tunnel syndrome, hand position dependent, and or nocturnal pain, numbness, and paresthesia of pain, and second to the fourth digits. What are the pain patterns of the hip disease and the trochanteric pain syndrome? As you see, the dark shading indicate the site of maximum pain. The hip pain could be trochanteric bursitis, could be hip local causes, could be referred to the knees, could be referred to from the knees. What are the causes of hip pain? What are the causes of hip pain? Osteoarthritis, the pain typically on the groin, worse on weight bearing. On examination, there is limitation of range of motion and pain on hip movement. The gluteus medius enthesitis, typically the pain is on the upper lateral thigh and typically worse on the lying on the lateral or that side at night. Tenderness over the greater trochanter is present on examination. the trochanteric bursitis like the above, and adductor tendinitis, which include or caused by spa-related enthesitis or sport-related trauma. Typically, the pain is on the upper inner thigh, and on examination, there is tenderness over the adductor origin, tendon muscle, tender or muscle, and pain is reproduced by resistant active hip adduction. Another cause of hip pain we have ischiogluteal enthesitis or bursitis. The pain is on the buttock, worse on the sitting, and there is tenderness over the ischial prominence. We have pubic symphysitis, which can mimic intra-articular hip lesion, and the pain is on the medial groin and can radiate to the inner or even outer upper thighs. On examination, there is tenderness over the symphysis joint. If pain is worse on trunk, curl, rectus activation under symphysis resting hand, it may be insertional rectus enthesitis due to SPA. What are the causes of knee pain? Remember that the most common cause of knee pain in middle-aged and elderly is osteoarthritis. Typically, it is weight-bearing on ascending and or descending movement. On examination, there is enlargement of the tendon joint. Tenderness are the joint margin, and there's crepitus on flexion. Some effusion sometimes you may see, and there is sometimes quadriceps muscle wasting. Other cause is, the second cause is prepatellar bursitis. Typically, the pain is over the patella, and on examination, there is tender fluctuant swelling in front of patella. The third cause, superficial and deep infrapatellar bursitis and fat pad syndrome. Typically, the pain is on the anterior knee, inferior to the patella, and on examination, there is tenderness in front of or behind the patellar tendon, pain on flexion also. The anserine bursitis is the fourth cause. Typically, the pain is on the upper medial tibia. On examination, there is tenderness plus minus swelling over the upper medial tibia. Medial collateral ligament lesions, injury or enthesitis. Typically, the pain is like the anserine bursitis, upper medial pain, and there's localized tenderness of the upper medial tibia. And the pain is reproduced by valgus stress on partly flexed knee. Other cause is popliteal cyst, Baker cyst, popliteal fossa pain. On examination, there is tender swelling of the popliteal fossa. We have the patellar ligament enthesiopathy, and we have the osteochondritis of patellar ligament, or called Osgood-Schlatter disease. And both of them, the pain is on the anterior upper thigh. For patellar ligament enthesiopathy, the tenderness is over the tibial tubercle, while for the osteochondritis, the pain is on resistant active knee flexion. We have some notes about knee pain, which are important. Osteoarthritis, most prevalent cause of knee pain in middle-aged and elderly people. Meniscal tear and or osteochondritis dissecans associated with knee locking, a sudden painful inability to fully extend the knee. Referred pain from the hip, present at the knee, but reproduced by hip movement, not knee movement. The periarticular lesions, pain well recognized to the involved structure. The anterior knee pain. It is typically due to the patellar ligament or retinacular lesion, like enthesitis, tendinitis, fat patch syndrome, and often caused by overuse or axial spondyloarthritis. It is more common in adolescents and possibly due to patellar articular cartilage or ligament insertion osteochondritis. What are the causes of ankle and foot pain? It depends on the pain location. For the ankle tibio-talar joint, the most common cause is osteoarthritis and osteochondral defect. Typically, the pain is between the malleoli, worsens on weight bearing. The subtalar joint pain, like above, but typically the pain worsens on weight bearing. Ankle joint pain, mostly caused by inflammatory seronegative arthritis, like psoriatic arthritis, or seropositive like RA, crystal arthritis, CPVD, and gout. The pain characteristically worsens and swells with rest and may involve hindfoot tenosynovitis. The underheel pain, heel pain, typically caused by plantar fasciitis, and characteristically the pain is due to overuse or as manifestation of spa enthesitis. It is treatable with rest, footwear adjustment, and sometimes local injection and exercise therapy is very important. Back of heel, Achilles tendinitis and enthesitis, metatarsophalangeal joint, typically caused by RA. The characteristic pain of MTP joint, symmetrical pain, worsens while walking, feels like walking on marbles. The first metatarsophalangeal joint pain. The most common cause is OA or psoriatic arthritis, and characteristically the pain is associated with hallux valgus or dactylitis. Hallux big toe, gout, classical target in acute gout attacks, and the pain between the metatarsal heads. Remember this, very important. Although it's rare, but it can be seen in the clinical practice. The pain between the metatarsal heads is mostly caused by Morton neuromas. And characteristically, the pain is characterized by neuropathy, usually between the third and fourth metatarsal heads. It is common in women and treatable with footwear and footwear adjustment, local injection, exercises, appropriate exercises, and or surgery. Now we will come for two important questions. We will do a quiz, and your job is to find the correct answer. The first quiz: what is the most common cause of acute back pain in middle age 20 to 55 years old? Infection, axial spondyloarthritis, mechanical back pain, malignancy, spinal canal stenosis. You need to go and search to find the correct answer. The second question: which condition is a common cause of elbow pain due to repetitive trauma? Osteoarthritis, lateral epicondylitis, rheumatoid arthritis, Paget disease, axial chondrocalcinosis, or CPPD disease. And thank you.